Poor Tara is in Auckland. Auckland. Now, hopefully there's no earthquakes around you, Tara. I'm just looking at the headlines here on Twitter. Hopefully you're safe and well.
I am, thank you. Yeah, can you hear me? I'm hoping there's no major delay coming all the way around the world.
We can hear you very well. Tara's an anaesthetist. She completed the College of Anaesthesiologists of Ireland training scheme in 2019, almost like you did premonition. You moved to Auckland in January 2020. You have a special interest in the impact of our working environment, our work culture, and making the workplace a better place. You've published on various topics, but pertinently on the impact of deaths on non-consultant hospital doctors working in the PICU, as well as 2 recent publications exploring the psychological impact on critical care workers of working through the current pandemic. And we're delighted that you're here today, and we appreciate that it's very late now in the evening. It's probably almost midnight in Auckland, Tara.
Just gone.
Just gone. Okay, well, fire away. And we're delighted you're still on, and I hope you have a cup of coffee there to maybe it's cocoa, but coffee. Then you don't look exhausted, so we'll let you go and present so that you can get on with whatever you're going to do after this.
Gin, I think it's probably a bit early for you guys, but I can have it. So good morning, everyone. As Claire says, I'm Tara Feeley. I know some of you who are here, most of you I do not, so very nice to meet you all. And thank you, Claire, for that very kind introduction. And also, I suppose, really, a massive thank you to Professor Greenberg there. That was an unbelievable talk, really just so informative. And Dr. Okafor, wow, that was really very powerful description of, I suppose, what it is we're here to talk about, the dreaded COVID-19. So just a tiny bit about me. So as Clara says, I'm currently working in Auckland. I'm actually working as a paediatric anaesthetist in Starship Children's Hospital at the moment. And as she says, it's not quite as safe in Auckland as it's deemed to be from a COVID point of view. Anyway, yeah, we had a major alert this morning from the civil defence telling us to get to high ground to avoid a tsunami. But anyway, the threat seems to have passed. So I've been invited here to share the findings of a research study that was carried out in early 2020. And the study resulted in 2 publications, and it was the result of a huge team effort where we had 408 respondents, as well as a large number of co-authors and collaborators. And the study took place in the critical care units in Tala, St. James's Hospital, Crumlin Hospital, and Temple Street Hospital. So 2 pediatric intensive care units and 2 adult intensive care units. So the first study that we had published was published in the BJA late in 2020. And this published our quantitative data. And the second study was published just this weekend, actually, online over the weekend. And this presented the qualitative data from the study. And both of these studies or articles are freely available in their entirety, so please do have a look if you have any interest. But I think more importantly than producing these publications, the findings of these studies have obviously been fed back to the 4 institutions involved, and the findings have been utilised for grant applications, in seeking additional support for staff who are working in these critical care units. So I think it is worth investigating what's going on around us and using the results the best of our ability. So what's the background to all this? So it's already known from lots of research on staff who worked in the original outbreak in China, as well as in lots of the other pandemics that fortunately never touched Ireland, but really did affect large numbers of people. So we already know that staff working in adult ICUs face issues including increased workloads, obviously a risk of infection, big concerns about infecting others, difficulties with PPE, and as Professor Greenberg discussed so eloquently earlier on, moral distress, which is generally associated in this circumstance with decisions around resource allocation in the context of kind of needs and resource availability mismatch. But at the time that we carried out this study, or considered establishing it, so that would have been in early March, April, May, June 2020, there was nothing published on the experience of PICU staff working during a pandemic. So we had a couple of aims, and these were, number one, to assess the degree of psychological distress experienced by healthcare staff working in both the paediatric and the adult ICUs in the context of the COVID-19 outbreak. And we had a second aim to explore the coping strategies of staff and uptake of available supports. So what did we do? We carried out a cross-sectional multi-centre study with 2 adult ICUs and 2 paediatric ICUs, as discussed earlier. The study consisted of anonymous questionnaires, and I think ours was probably slightly different to many other studies that have been carried out in that we invited all staff working in critical care, so both the clinical and the non-clinical, because we felt that without the non-clinical staff, the ICU or PICU simply was not going to function. So it was important that we gathered data about the experiences of everybody who makes these critical care units work. And as I say, the data was collected in May and June in 2020. So you'll recall one of our aims was to assess the degree of psychological distress experienced by healthcare staff working in both the paediatric and the adult ICUs. So we used 2 validated tools. So the first one that you can see there on the screen is the Trauma Screening Questionnaire, so the TSQ. And the second one, which doesn't roll off the tongue quite so much, is the MMDHP, so the Measure of Moral Distress for Healthcare Professionals. And we also added in some open questions at the end as well. So looking at what the TSQ is, it's a 10-item symptom screen, and it was designed for use with survivors of all types of traumatic stress. It's a simple 10-question assessment, and it asks questions on 5 re-experiencing items and 5 arousal items. So an example of a re-experiencing question is seen there on the screen. And here you can actually, sorry, I'll just zoom in there. And so here you can read an example of an arousal question. So each of the 10 questions is a binary yes or no answer. And each question that gets a yes response scores 1, and then a total score of 6 or higher indicates that the respondent has an increased likelihood of developing PTSD. And again, I'd echo Professor Greenberg's statement that this is not diagnostic, and these are self-reported tools, but it certainly gives us a good indication that people who score higher than 6 on these are just at a higher likelihood of developing PTSD or other psychological sequelae to their experiences. So the other psychological impact assessment tool that we used was the Measure for Moral Distress for Healthcare Professionals. And as the name suggests, this was devised for use by healthcare professionals. It consists of 27 items, and it's usable by all healthcare professionals in all clinical areas. It represents the most currently understood causes of moral distress in this group. And you can see an example of the questions on the screen there. So you can see that the respondents were asked to score both the frequency and also the level of distress associated with these events. So next, moving on to how did we inquire about the coping strategies? So this, I'll just zoom in here now. So this is the brief cope, or a sample of the brief cope questionnaire. So it's a 28-item questionnaire. It's designed to measure effective and ineffective ways to cope with a stressful life event. And just as an aside, so coping is defined broadly as an effort used to minimize distress associated with negative life events. So looking at the questions on the screen here, I think we can all agree that option 2, which reads, "I've been concentrating my efforts on doing something about the situation I've been in," is a positive strategy. It's known as approach coping. And this is characterized by strategies such as positive reframing, planning, acceptance, seeking emotional support, and seeking informational support. Approach coping is associated with more helpful responses to adversity, better physical health outcomes, and generally more stable emotional responding. In contrast, Avoidant coping is exampled in option 4, and you can see down the bottom there, it's I've been using alcohol or other drugs to make myself feel better. So avoidant coping is characterized by strategies such as denial, substance use, venting, disengagement, self-distraction, and self-blame. Something we're probably all a bit familiar with. Would probably be far happier if we could say we're better at the approach coping, but certainly everybody dips into avoidant coping every now and then. However, it is associated with poorer physical health, and compared to the approach coping, avoidant coping is shown to be a less effective strategy for managing anxiety. Then we looked at what supports the respondents found most useful. A list of available supports was provided to respondents, and they marked all of those which they found helpful. I mentioned earlier that we included free text questions in our survey, and this helped us to obtain a richer picture of the ICU and PICU worker experience, delving into qualitative data collection. So just to have a quick look there at the 4 questions. So are there any factors related to the current crisis that are causing you stress currently? Are there barriers or obstacles to making use of the available supports? What other supports would you or your colleagues benefit from but are not currently provided? Do you have any other comments or information about your experiences you would like to share? So you can see they're very broad questions, and it allowed people really to write whatever they wanted, to be honest. So just to talk about our results, so also just really to note that the context of this survey, so a couple of things. Firstly, even before the arrival of COVID to our shores, you're all healthcare professionals or very closely associated with this, so you don't need me to tell you that Irish healthcare workers were already working in an overburdened and under-resourced healthcare system with severe bed and staff shortages. So it would be fair to say that the pandemic amplified existing workplace shortcomings, as well as exposing healthcare workers to a whole new set of new workplace stressors. So who are our participants? So I'm hoping that these images will give a good demonstration of the patient or the participant group. So 67% were nurses, about 17% were doctors, and nearly 9% were allied health professionals such as dietitians or physiotherapists, and nearly 7% were general support and administrative staff. 81% of our respondents were female, and that really does correspond well with the gender breakdown in critical care. The majority of critical care workers are female. We had a pretty even balance between the respondents from the PICUs and the ICUs. So looking at the trauma screening questionnaire, just to remind you that a result of 6 or higher indicates the individual is at a higher risk of PTSD. And so you'll see from the results on the screen that those working in PICU were just as likely as their ICU colleagues to score highly on the trauma screening questionnaire, and with all the implications of this. So 14% of all critical care staff were at significant risk for the development of post-traumatic stress disorder. And obviously this is very concerning, given its association with personal turmoil, risk of substance abuse, burnout, suicide, and of course, impact on patient safety. Looking at moral distress, working in the adult ICU, having greater exposure to Covid-19 patients and redeployment to ICU were all associated with greater or higher moral distress scores. And it was interesting in reading, so there are, as I say, a number of questions that the respondents answer in order to obtain their moral distress score. But the greatest distress was expressed towards the statement of being prepared to work with other healthcare team members who are not as competent as the patient care requires. And that fact is likely linked to the fact that there was such a high proportion of the staff redeployed from the wards and other locations to work certainly in the adult ICU. So over 50% of ICU staff stated that they had cared for over 15 patients with COVID, while no PICU staff member had cared for that many. And you'll be able to see that here. I've just highlighted it for you here. So on the left, you can see the exposure to the number of confirmed COVID cases, and then comparison between the PICU and the ICU staff who've been exposed to that number. So very interestingly, the staff who had cared for between 1 and 5 patients with COVID compared to those who had cared for none were just much more likely to have a higher moral distress score. And staff who stated that they had been redeployed, you'll note that most of these were working in the ICU down the bottom highlighted line there, and they were much more likely to have a higher moral distress score. Interestingly and different, I note from what Professor Greenberg found, and being quarantined and working extra shifts or longer hours wasn't associated with an increased score in the measure for distress in our cohort anyway. After an analysis of factors related to high trauma screening questionnaire scores, you can see that there are a few risk factors or associated factors. So being white Irish, scoring highly on the measure for moral distress scale, and then using maladaptive strategies. So these were all associated with having a higher trauma screening questionnaire score. So I'm not going to show you very many graphs at all because I know it's very hard to look at a whole screen full of them, but there are only 3. So this here looks at the sources of stress for participants. So I'd like you just to look towards the right-hand side of the chart here, and you can see that the dark blue and the navy, they represent the extreme stress and much stress as experienced by the participants. So once you train on your eye on that, you can see that the standout scores for stress for ICU and PICU staff were worry of passing the virus to family, very understandable, concerns about the shortage of PPE, and again, that's the theme that comes up over and over again in the literature, becoming ill with COVID-19 themselves, and it's very interesting that that is ranked lower than the 2 aforementioned sources of stress. And again, the shortage of staff, again, another big cause for stress for people at this time. Okay, so this is another graph and it looks very busy. So I apologize, but please stay with me. So essentially, this represents the use of coping strategies by our respondents. So you'll recall I mentioned approach or positive strategies and all the benefits of those, including its association with more helpful responses to adversity. So the approach strategies I've marked with a green little dot there at the end. Meanwhile, the avoidant coping is shown to be a less effective strategy at managing anxiety, and these are marked with red. So I think it's really worth highlighting that across all the professions, I won't go into the breakdown of them, but you can see that across all of the professions, acceptance, positive reframing, use of emotional support, these were all these positive means of coping were far outnumbered or were ranked far more highly than the negative coping strategy. And interestingly, the nurses had a far higher use of most of the coping strategies, and there's a statistical significance in the coping strategies marked with the asterisks there. So this is the last bar chart. So you'll recall staff were asked to simply tick which resources they found useful. They didn't have to rank them. So again, echoing what Professor Greenberg has said, and Ike as well, I think really in terms of your own experience of it, people found that informal debriefs with their peers were absolutely the most beneficial resource and support in dealing with the extremely difficult circumstances that people were dealing with in May and June last year. People also did find that departmental debriefs of critical events were useful. And so it's very clearly the environments and the colleagues and the structures at work that members of every profession find to be most beneficial when it's well established. And this really feeds into the literature. There's a lot of recent literature coming out that says that promoting good relations between colleagues at work and providing organic spaces to interact, having really good discussions about the good, the bad and the ugly of clinical life, all really contribute to better coping strategies by the staff. So I mentioned that we had 4 free text questions that were included in the survey, and the responses to these were coded and then themed into seven overarching themes that you can see in the table here. I think it's hard when you're looking at this to really gain an understanding of what responses and what information was given in these. And to be honest, the 4 free text questions nearly gave us the most interesting data of the whole thing, because I suppose people just nearly journaled their account. And honestly, some of it, reading it, some of it was harrowing. But anyway, I will let the respondents express themselves, and I'm going to share a selection of their comments with you. So this is a selection of comments with staff describing their experiences. So I'll let you kind of read through them, and I'll talk a little bit in the background. These comments really are all indicative of staff who are under extreme personal and professional pressure. So I've never been so stressed in my life. I was put on a ward. I was a ward nurse put onto an ICU with not enough support. After 1 hour training, I was given a patient on a ventilator and dialysis. I was so scared I would cause harm to this patient. There are lots of quotes similar to this that we received, and really all of this again fits in with what Professor Greenberg was saying, was that you need to give staff training. You need them to know what it is that they're stepping into. You cannot give them roles for which they're not prepared, either psychologically or in experience. And you can read through some of the other ones there. I mean, there were some positive comments, such as, I am lucky to be working in a fantastic ICU where everyone supported each other, was one. Medical preparation was excellent in ICU, staff and equipment was there. And so it was very nice to read some of those comments, but the truth is that these types of comments were very much in the minority. Again, this is just a selection of comments that where staff described what they needed. So a lot of the anxiety that you can read and elicit from these comments here relates to the staff feeling that they didn't have even the most basic of requirements. And you're all a very educated group, so I know that you'll be familiar with Maslow's hierarchy of needs. And this is where the most urgent and basic of needs are at the bottom of the pyramid. You'll remember the different colored stripes of the pyramid. And so the most basic needs are the physiological needs. So food, shelter, i.e. a home. You can see this poor fella's comment down the bottom there on the bottom right. Sleep, rest. All of these were identified as not being provided or being taken by work. People were working long hours. There were no food outlets available in the hospital. All the shops were closed. People were absolutely exhausted. And then moving up that Maslow's hierarchy of needs, safety needs are the next ones up. And those safety needs that were violated here include the need for health, the need for financial security, and basic safety. So we have devised a visual representation of the interplay between the external factors. So you can see them on the outside there, so personal factors, and of course work-related factors, which can all contribute to occupational stress during the COVID pandemic. So in a large part, the work environment appears to have dictated the emotional and psychological responses of the healthcare staff. And additionally, the unique nature of the pandemic presented additional stressors to the healthcare workers. I mean, it did to everybody out in the whole of society, but I guess it's the healthcare workers that we're particularly looking at here. So things like societal restriction on non-work activities, social, family engagement, regular exercise, spiritual pursuits, all of that obviously was taken away from people. And it was for everybody. It wasn't obviously just the healthcare workers. But again, that's part of that psychological PPE that was mentioned earlier on. You know, prepare yourself, do the things that normally bring you calm, peace, a bit of restoration, and a lot of what people do to make themselves feel better was taken away from them at the time. So just in conclusion, really, I'll let you read some of the conclusions there, but the message that came across loud and clear in our survey was that staff wanted to feel, firstly, they wanted to feel heard. They expressed having problems with accessing childcare, not getting adequate rest. They felt that they were absolutely exhausted because they had no respite from non-COVID duties. And like, this is just a few of the concerns. And the second thing is that staff wanted to be spoken to. So again, it's all about communication. Many of the staff were so frustrated with frequently changing guidelines, poor communication of plans from their managers. And very sadly, loneliness was such a big theme in our findings. The loss of communal workspaces, communal spaces at work was very keenly felt. And it seemed to compound the loneliness of not seeing friends and families and loved ones outside of work. And I think here, I haven't really heard anything mentioned about this, but I would just like to mention with regards to the many healthcare staff working in Irish hospitals who are originally from overseas, because there was so much anguish expressed by these people about the severity of the pandemic in their own home countries, as well as their grief at not knowing when they would ever be able to return home. I'd also like to point out that the supports that were ranked most highly with the staff are easy to facilitate. So peer support, departmental debriefs, that's also achievable. Some of the supports that were ranked less highly included the Employee Assist Programme or psychological support. Obviously, it was very interesting to hear the fact that we shouldn't go in and give sort of hot debriefing, but we did wonder if maybe these were ranked less highly because there are barriers that exist to accessing these supports. So for example, if you want to access them, you're not given time off to access them. So you have to do it within your own spare time or home time. And as ever in healthcare, there's unfortunately a perceived stigma to accessing or to utilising formal psychological supports. So I hope this has been a useful overview to our findings, and I hope more importantly that it has given some guide as to what can be done to ensure that the workplace is optimised for our essential frontline workers. So thank you all very much.
Thank you so much, Tara, for that fantastic presentation. It's so lovely to see and indeed to read about the study that we did over 4 sites last May. Very interesting findings, and because we either work or know people who work in these settings, so we're very connected to this, we're very invested in this, and the findings are very relevant, very relevant, and they do tie in with what Professor Greenberg spoke about earlier, and the fact that some of the measures that can be put in place locally quite cheaply, they're not resource intensive, but it's about the will to do that. And I think the stigma that you spoke about at the end, it's very real, and it is a barrier to staff accessing that psychological support that they need, or sharing the distress that they're under, and that they do need some support. So I think that we have to look at that. There is a question actually which relates to that also. It's from Bernadette. Oh, it's disappeared on me, sorry. She did ask about if we are going to re-audit to see where we are now compared to last year and the first wave of the pandemic. Yes, here it is again, sorry. Is there a plan to re-audit this year to compare the results to how the healthcare workers are coping now, especially as organisations know more and have more support systems in place?
Yeah, it would be interesting to do, wouldn't it? I think the thing with all of these, and Claire will second this because she was very involved in this, is that this took months of our lives for a lot of people. So while it would be an absolutely very worthwhile thing to do, I think I'm not sure how feasible it is in terms of what people have just got time to do. But certainly on a local level, the key findings from this could be utilised by the managers working in each not necessarily just the 4 units that we surveyed, but all units all around the country, and just make sure that the supports that we've shown are useful, make sure that they're available, make sure that the complaints or causes for just absolute distress and agony, make sure that they're being minimized, and certainly it could be re-audited on a local level. The questionnaire that we used was published or attached, I think, to both of the papers, and if you can't access it, you're more than welcome to contact me and I can send it on to you. So that's freely available for people to do at a local level, and actually that might just have more impact as well, I think. Claire, what do you think?
I do, yeah, absolutely. That's definitely something we could look at.
It's freely available.
It is, yeah, and it's published now and it's accessible for everybody. And we have you have the link there on your first or second slide. Tara, there's another question here. I think it's from Aoife Brinkley. Do you have any thoughts on why rates of trauma symptoms were similar across PICU and adult ICU staff, given that there must have been quite different impacts in these settings?
Yeah, so the amount of data that we collected was absolutely enormous, and obviously I couldn't cover it all in the 20-minute talk, mostly because I don't speak as fast as Professor Greenberg. But yes, so like PICU staff were absolutely distraught because you'll remember, and I asked you just to bear in mind the time of year that we took this. So really, we were only just over the peak of the first wave. And really anybody who thought about it knew that there would be more waves. So the stress and the distress for PICU staff really related to the fear of the unknown. So would the children start getting sick? So there was a thought that the children who were initially asymptomatic, would they then have this long COVID? And forgive me now, I've forgotten the name of the pediatric inflammatory response to COVID that was, so there was such fear, like would they be getting hundreds of children coming in with this dreadful disease that would affect their central nervous system? Then there was obviously the fear for themselves. Were they going to be, there was no elective surgery going on in the pediatric hospitals. Were they all going to be shipped off to go and work in adult intensive care units, or worse, were adults going to be brought into the little children's beds in the pediatric intensive care units? They were all concerned about their own children, and really they shared a lot of the concerns that the adult ICU staff had. So the concerns about the PPE, the concerns about all of their spouses who seemed to be like nearly en masse. It sounds like most of the country was nearly put onto the pandemic unemployment payment. And that's not the life that people had set up for themselves. Their mortgages were not set up to be paid with the pandemic unemployment payment. So really, although their sources of distress came from different perspectives, there was some overlapping, but really, yeah, it was absolutely dreadful for everyone.
And certainly, Tara, some of the PICU nurses have gone into the adult ICUs to support, depleted rosters as well. So it's great that kind of collaboration has been seen, and everybody working together and rolling up their sleeves. We've time for maybe one more question, and that will be from, Bernadette did say that it's great for individual organizations to do the questionnaire. Yeah, and that's available. Did the text comments talk much about respondents' families and family commitments and connections?
I didn't hear that. Sorry.
Did the text comments talk much about respondents' families and family commitments? Yeah.
Yes. Yeah. So again, that's something I only glanced on at the end. So so many of our hospital staff have young children. And although I'm the first to say it shouldn't be the woman's job to look after what happens to the children, or it shouldn't be just them looking after the kids. Unfortunately, it is in a lot of households. And so, as I said, 81% of our respondents were women.
Yeah.
So a lot of these women were in their 20s, 30s, 40s, and some of the men obviously as well. And they were absolutely exhausted. They were they were looking for people to look after their kids when they were working in with the sickest people in the country. Then they were going home and they had absolutely no downtime because there was no childcare available at that time. I know things have changed in the meantime, but yeah, certainly there was, people were like, you were reading some of the comments was so distressing, because really it was people just on the verge of just giving up altogether. And some people really did mention that they were talking about, just give up the job, take the unemployment payment, because that seemed to be the only option that they had. And really, I think that all just feeds into how much the staff felt that they were not listened to. And again, echoing Professor Greenberg, communication was the big thing. So people feeling that, they were leaving their children at home with grandparents who they felt were maybe vulnerable to having the disease. There just was no plan in place. Like, how were all these workers going to come to work with their children at home and nobody to look after them? There wasn't a plan. And in the best of times, there isn't a plan, and there is no childcare facility on most hospital sites, and there isn't free childcare for essential workers or reduced rates, etc., etc. And that is bad enough in the best of times. And as I say, we're coming from a starting point of a really pretty poorly resourced healthcare system. But yeah, so there was a lot of talk about the children and the families. Yeah, sorry, I rambled a bit there.
No, not at all. No, you've come full circle, because that you did start with that. The burden that came onto an already pressurized system. Yeah, there is a lot of positive comments coming your way. Very informative talk, lots to think about and lots to act upon. Thank you, Bernadette, for that. And Sandra Morton, very important study for female-dominated healthcare.
Thanks, Sandra.
So thank you, Tara.